Hi everyone in YouTube land, this is Rick McDermott here with Senior Solutions Group and reporting to you regarding my recent trip to Washington D.C. last week, where I was at the NABIP, the National Association of Benefits and Insurance Professionals National Annual Washington D.C. Conference. And we are here to fight for you. NABIP, formerly NAHU, N-A-H-U, they just changed their name this last year, has been around for almost 100 years, and they are the primary organization that is fighting for private sector sensible solutions to lower your healthcare cost, your insurance cost, and provide access to care across the country. There's arguments all over the place. The Bernie Sanders, people that want single payer. The argument is that, oh, that would be better if we had national health care like they do in England. Well, talk to people in England. They're becoming more and more unhappy with their system. So there's a lot of fraud, waste, and abuse in healthcare, and Medicare is not exempt to that. And we are looking for ways to lower your cost so you can get affordable health care at a reasonable price and have access to good care without reducing your benefits. We can save Medicare without cutting benefits. So as I said, for nearly a century, by the way, Washington is an amazing city. If you haven't been there yet, you owe it to yourself to find out how our government works. There's a ton of museums that are free. I got to see Arlington National Cemetery, and my gosh, it was so moving to see the changing of the guard ceremony. Very sobering. And it's just a really cool city. Got to see where Abe Lincoln was shot at Ford Theater and where he died across the street in the house across the street. Met a lot of amazing people, met some senators, some congressmen, some staffers. They were all very accommodating. They wanted to learn from us, and we got to learn from them as well. They asked that you be patient with them. Senator Mike Rounds of South Dakota spoke to our group, said, please be patient with us. He's an actual former insurance agent himself. He used to be the governor of South Dakota prior to Kristi Noem, and got to hear from a lot of different voices. Senator Bill Cassidy out of Louisiana spoke as well. We're going to have several parts, probably 3 or 4 of these videos recapping our visit. The main talking points with NABIP for this 118th Congress, they are supporting, I'm going to focus on Medicare today because that's our specialty, is Medicare. So NABIP supports excluding licensed agents like myself and brokers from burdensome marketing restrictions. So these boilerplate call centers that are causing so much havoc across our nation, switching people's plans without their knowledge, not giving them full disclosure. Those are the people that caused this to where now all agents have to record their phone calls, which may not be a bad thing because sometimes having a call recorded is good for not only you, but for us as agents. If there is a complaint, we can go back to the call and listen to it and say, no, we actually told you this. Yeah, here it is in the call recording. That doesn't happen very often, but on occasion it can happen. Also, COBRA being treated as credible coverage. So if you lose your employer coverage and go on to COBRA, we are advocating that you can use COBRA as credible coverage and not pay a lifetime of late penalties if you come off COBRA onto Medicare. Observation status, treated as inpatient status in a hospital, so you can use your hospital stay to be transitioned into a nursing facility for skilled care. We're going to talk about that in a later video. Open enrollment for Part D. So currently people on Medicare Advantage have an extra 3 months from January 1st to March 31st to change their Medicare Advantage plan one time. So you can only do this one time between January and March 31st. So if you were enrolled in a plan, you found out it wasn't the plan you thought it was. By the way, in the springtime, that's when Medicare sees a lot more complaints. When the rubber meets the road, when you start using your plan, it's not the plan you thought it was. Why not have that for people on regular Medicare, original Medicare, who have prescription drug insurance through a standalone Part D drug plan? What if you go to your pharmacy in January and you go to refill your drug and now your pharmacy's out of network? Well, if you're on regular Medicare, you can't change your plan. You have to go to a different pharmacy to get your drugs filled. So if your favorite pharmacist is no longer in network and you like your pharmacist, you don't want to change, you're stuck changing to another pharmacy or paying the full cost out of pocket. Why not have an extra 3 months, like people on Medicare Advantage do, to change your drug plan? Or if your drug plan no longer covers an expensive drug you're on, you should be able to change your drug plan just like people on Medicare Advantage can between January 1st and March 31st. So currently you can only change your drug plan from October 15th through December 7th. We want to extend that an extra 3 months. So the first thing I want to talk to you this week in our topic is site-neutral payment reforms. So over the last several years, maybe the last dozen or so years, we've had a ton of clients say, yeah, I go to my doctor and I get this extra facility fee. It could be $100, $150. We've heard as much as $300 for these facility fees. What's happening is hospitals are gobbling up doctors' offices nationwide. We're seeing consolidation across the whole country. NABIP members, as we went to D.C. last week, talked about this. So currently there's bipartisan support to help lower the cost of people who go to the doctor's office. Currently, providers that own multiple facilities, so these hospitals that own doctor's clinics, they can charge different amounts for the same care depending on where the care was received. For example, the price of an X-ray or an MRI at a freestanding facility versus an outpatient hospital setting. So as these providers consolidate, they continue to consolidate across the country amidst record-breaking mergers and acquisitions. This has continued to grow as an industry issue. So the concept of regulating this practice so that the charge is the same regardless of setting is known as site neutrality. So we've got a bipartisan bill. Right now we've got a divided Congress, so we don't see a lot of things happening unless we see bipartisan support. This is gaining bipartisan support. It was introduced late last year, this bill. It was also supported by the Trump administration and the Obama administration as well. This would require doctors' offices owned by hospitals, which we have where we live. We have a lot of doctors' offices owned by the hospital here that have unique billing codes so that payers know where their care is delivered. While the bill did not gain significant traction in the previous Congress, it is expected to be reintroduced in the House in this session, this current session, and is considered in the Senate as well. It will be considered in the Senate as well. So again, the Congress is divided, so the only healthcare items that are going to be passed are ones that have bipartisan support. Location-based gaming of coverage occurs across all markets, including the Medicare market. Medicare presently lets hospital-owned clinics be designated as outpatient departments and net a higher payment for certain services than if they were owned by the clinics as independent clinics. This is despite little evidence that the quality of care differs substantially between locations. According to a report from the Committee for a Responsible Federal Budget, a nonpartisan organization that studies fiscal policy impacts. So making these Medicare payments site neutral could reduce spending by $153 billion with a B over the next decade. And according to a Congressional Budget Office CBO estimate from 2020, it suggests similar savings, $140 billion over the next decade. Okay, now we're going to hear from Heather from the Alliance for the Fight for Healthcare, and let's hear what Heather has to say about this at our conference.
You on a little field trip for a moment. I want you to imagine that you're a little bit thirsty, that, NABIP didn't offer enough, sort of free drinks, enough free coffee. And so you have to figure out where in this great city you want to go to get a soda. It could be a soda if you're from the South, or a Coke if you're from the West Coast like me. You pick your poison. So you're a little bit thirsty and you're thinking, okay, where do I want to get my Coke? So if you decide that you just want to go to the grocery store and buy a can of Coke, let's say that that would maybe cost you, $2 from the machine, maybe $1 at the store. But if you went to the 7-Eleven on the corner here, it could cost you maybe $2.50. It would be a little bit more, right? Because they're adding a little bit extra. But if you went and sat down in one of our nice, fancy restaurants, and I hope you do, so they stay open, they're going to charge you about $7.50 for that exact same Coke, right? That Coke isn't any different. It's not any sweeter. It's not any colder. It is the exact same Coke. So what's happening in healthcare is that the federal government has set up a little incentive here that's creating a problem. And what's happening is that $7.50 restaurant is taking its name and pasting it on the front of that soda machine. And when they do that, you're still getting the same Coke, but they're now charging you $7.50 because it came out of a machine with their name on it. In fact, it might not be $7.50 anymore. They might actually add on an additional fee just for using their machine. This is why we want to talk about site-neutral payment reform. We want everyone in healthcare to pay for the Coke that they're getting, but we don't want them to have to pay those restaurant prices. So site-neutral payment reform at its very base level is just the concept of paying the same amount for the same care, irrespective of where you receive it. So if you're having your ear checked and you're paying $25 to have your ear checked, you're going to pay $25 to have your ear checked, whether you have it done at your doctor's office or if you have it done in a hospital outpatient department. So let's talk a little bit about what is happening to drive this up. I really love this conference because all of you know a lot about healthcare coming in, and so I want to take you just a little bit deeper than I would most audiences so you can understand the policies underneath that are driving these disparities. The other thing that these disparities are driving is a lot of consolidation, right? That hospital is now making, $7.50 more by putting their name on that Coke machine. So what's happening is they're going out and buying all the Coke machines. So hospitals are being incentivized by site-neutral payments, or the lack of site-neutral payments, to go out and buy up all of the physician's office. This is causing consolidation and increased prices and reducing competition in our economy. This is driving up prices for patients, for employers, and reducing our ability to sell products to people. So, what's doing all of this? The Medicare program pays for care in two different ways. They have one set of prices that they pay doctors when they have a doctor's office, and they have another set of prices that they pay hospitals. Well, the prices that they pay hospitals are higher than the prices that they pay doctors. And so those hospitals figured out that they could just go and buy those doctor's offices and charge hospital prices. So what does that mean? If you're a cancer patient, that means that if you get your chemotherapy in a doctor's office, that's one price. If you get your chemotherapy in a hospital setting, that hospital gets paid 141% more for the exact same treatment. If that hospital goes and buys your doctor's office and changes the name on the door, you're now getting that care in the exact same place with the exact same provider, but you're now paying 141% more for that care. So look, that's getting split between you, it's getting split between you and the insurer, so you're not paying the whole 141%, but you can almost think about that as the delta of the increase that you're paying in co-pays and deductibles. Is that difference, right? So you're now having to pay that much more for your copay than you would have otherwise. So this chart here that I have is an example from chemotherapy. So you can see the difference. 2012 is blue, 2019 is orange. And you can see here the increase in chemotherapy administration and the shift from physician's offices to hospital offices. Which one's increasing faster, the doctor's office visit or the hospital visit? Hospital visit. That is all translated to higher costs for employers and higher costs for patients. And it's a tool that hospitals are using to increase funding. So Medicare on average pays about 105% more for a visit in what's called a hospital outpatient department. So we're not talking about heart surgery here, right? Like nobody's doing heart surgery in a doctor's office. These are things that are on the Hill. They might call them HOPDs, hospital outpatient departments. We're talking about the kinds of things that could be typically done on an outpatient setting. It's about 105% more for an average visit in those cases. So this is an example for a 15-minute E&M visit. That's like your kind of average middle-of-the-road doctor's visit. They're going to evaluate what's going on with you and figure out how they're going to manage it. It's your typical doctor's appointment. You walked in. If you were walking in to your doctor's office before it's been purchased by a hospital, that visit is going to get reimbursed at about $39.76. Not about, that's an exact number actually. This was in 2013, it's gone up a little bit. Which means that you, as a beneficiary, are going to have about $9.94 in, beneficiary cost sharing. Not too bad, right? $10, you went to the doctor, that feels pretty fair. So let's say you come back the next month, and a hospital has purchased your doctor's office, and congratulations, you are now receiving care in a hospital outpatient department. Looks the same lady's answering the phone at the front desk. But now the hospital outpatient department, aka your previous doctor's office, is now getting paid $98.70 for that exact same visit. This means that you, as the beneficiary, will have to pay $24.68 in cost sharing. This has more than doubled what you are paying out of pocket for the exact same visit. Your quality did not increase. Your doctor didn't get any smarter. There isn't a brand new emergency room attached to your doctor's office. Those things did not happen. The only thing that happened is that the price went up. So what we're asking you to do is help us fix this.
Okay, so that was Heather from the Alliance for the Fight for Healthcare. I didn't catch your last name. Had some good tidbits. So yeah, the can of Coke analogy is one thing, but what if you need more than a can of Coke? What if you need a full meal? How much would you pay at the grocery store versus the fancy restaurant? You might pick up some potatoes, some ground beef, make meatloaf, and some carrots, and maybe splurge and get chocolate cake for dessert. You might spend, I don't know, $10 if you make it all at home per person, maybe even less. But if you go to a fancy dancy restaurant and get that same meal, you might pay $40 for that same exact meal at the restaurant when you have the dessert and the drink, the Coke. So if you need more than a routine office visit, maybe you have a procedure that costs a little bit more money. Well, that's going to cost potentially a lot more money. We had a client that came in today, and unbeknownst to me, he brought in his EOBs from Medicare. So when you go to the doctor, Medicare will send out an explanation of benefit summary notice on a regular basis. And basically what happened in his case, he went to the doctor back January 13th of this year, here where we live in Yakima, for a outpatient visit, 20 to 29 minutes, and Medicare approved that. The provider charged Medicare $78. Medicare approved $56.06, and he would be billed the $56.06 because he has not met his deductible yet for the year of $226. So every year, if you're on Medicare, you have a deductible of $226, which you would have to pay unless you have a Plan F or a Plan C Medicare supplement plan, which are no longer sold anymore. So everyone on Medicare has to pay the initial $226 if you're on regular Medicare. Now, we're not talking about Medicare replacement insurance, the Medicare Advantage plans. We're talking about regular Medicare, where Medicare is the bus driver and the insurance companies riding shotgun. So then he brought in this other EOB from the same date of service here. Well, lo and behold, the hospital purchased his doctor's office here where we live, and he has a facility charge of $166 added on to his bill. and Medicare will pay 80% of that, and he will pay 20%, but he hasn't met his deductible, so he has to pay the full $132.83 for that charge. So every time you go to the doctor, if you go to the doctor 4 times, that's another $700 that one person is paying. Who's paying for that? Who's paying for that? We are, taxpayers. In higher Medicare premium cost, higher insurance cost, higher premiums from the insurance company. So there's a lot of money out there that is being spent on these hospital facility charges. So his bill went from $56 for a 20-minute visit or a 28-minute visit to quadruple that, $166 for that one visit. So we've got a lot of cost out there that need to be contained. So here's another report, equalizing Medicare payments regardless of site of care. So again, over the next decade, this site neutral payment policy could reduce Medicare spending by $153 billion and reduce premiums. That's what you pay for your Medicare, because right now it costs $164.90 a month for Medicare. When I first started back in the mid-90s, Medicare was about $43. I think it was $43.80 when I first started. Now it's up to $164.90. And if you're on a higher income, you may pay a lot more than that. Last year was $170 a month. So this could reduce the premiums that Medicare beneficiaries pay and cost sharing by $94 billion. So that's assuming these different levels of private sector spillover savings, this policy could also reduce the national health expenditures by a range of $346 to $672 billion, reduce the federal budget deficit by a range of $217 to $279 billion, and reduce private cost sharing and premiums by a range of $140 to $466 billion. That's real money, folks. That's not chump change. You need to get a hold of your congressman and you need to tell them that we need to have this passed. We need to save Medicare. Medicare is going broke. People are going broke trying to pay for their Medicare. You know, we talk to people all the time who are trying to save money on their health insurance, on their supplemental insurance. Just the last couple days, we were able to help one person a day save $100 a month on her Medicare supplement premium. Why is her Medicare supplement premium $250 some a month? We were able to get it down to under $150 a month without changing her doctor. So if you have questions about that, let us know. Reach out to us. And by the way, feel free to subscribe to our YouTube channel and share this with a friend. People are hurting financially. We need to do what we can do to help people. I spent my own money going back to D.C. to fight for your rights, to save you money to get affordable health care. But it's your responsibility to do your part. Don't just sit back and let these things happen. Call your congressman, say, we need site-neutral payment policies. These hospitals that are buying up these clinics, buying up the Coke machines, putting the fancy restaurant name on the Coke machine where you're spending $7 for a can of Coke that should have cost maybe $1.50, that needs to stop. This insanity must stop. We need to take control of our health care, because you know who's paying for it? We are. So that's round one. Stay tuned for more. We've got more of this, folks. There's a lot more to come. Again, share this with a friend. Get the word out. Make this happen. We're going to see change, and it's going to be because of you guys. Thank you so much for taking the time to watch this video. We are here to fight for you. We're here to help you save money, increase your access to care. We are a Senior Solutions Group. Reach out to us today. Don't hesitate. Thank you so much.